Good morning. I am Dr. Ignacio Smith Montaño Callejas. First, I would like to thank the organizing committee for inviting me to participate in the first International Congress of Fetal Medicine and Gynecologic and Obstetric Ultrasound here in my country in Santa Cruz, Bolivia. I would like to thank the organizing committee, my colleagues, and fellow compatriot friends, as well as the Santa Cruz branch of the Society of Gynecology and Obstetrics and the Medical Association of Bolivia for inviting us to participate in this major event. I am going to present ISUOG guidelines for the examination of the heart in the second trimester. I do not have any conflicts of interest. The outline of the presentation is as follows: evaluation of the heart according to the ISUOG guidelines. We will review Yagel's 5 views, the technique, color Doppler, tips, and additional signs to improve the assessment of the heart in second trimester screening, and the indications for fetal echocardiography, the main indications, and finally, the conclusions. The ISUOG guidelines were updated in 2023 and are based on the 5 views proposed by Yagel: the abdominal situs, the 4-chamber view, the 5-chamber view, the right ventricular outflow tract view, the 3-vessel view, and the 3-vessel trachea view. The fetal heart evaluation in low-risk fetuses should always be performed. What the guideline proposes is that the outflow tracts should be included in the 21 to 24-week ultrasound, along with the 3-vessel view and the 3-vessel trachea view. And what is the objective? It is to confirm normal findings and to assess suspicion of a congenital heart defect. How? By increasing the detection of heart defects in low-risk fetuses. The best time, the most optimal acoustic window is between 22 and 24 weeks. High-resolution ultrasound machines should be utilized. High-end units with a higher transducer frequency, which helps to improve the detection of more subtle findings. However, there must be an appropriate balance between adequate penetration and overall resolution. Use harmonic imaging to help enhance overall image quality in patients with an increased body mass index. You should use the zoom function and then gradually enlarge the image until the heart occupies approximately 1/3 to 1/2 of the screen. Syn loop must be used to evaluate the movement of the AV valves and the semilunar valves throughout the entire cardiac cycle. The screening cardiac exam begins with the fetal presentation and the fetus's laterality in the uterus. We will follow the fetal axis, imagine the range of positions, and slide the transducer along the axis orthogonal to the fetal trunk. It is important to have a model, a doll, in our exam room to help guide us, especially when someone is just starting out, and especially for the residents. Both the residents who are doing their ultrasound rotation and may have a bit of difficulty. To assist us, we use a doll, and here we can clearly see the presentation. For example, here the fetus is in a cephalic presentation with the back on the left side. Therefore, the tip of the heart is on the left, the stomach is on the left, the right side is anterior, and the left side is posterior. We see the fetus in a cephalic presentation with its back to the right side down, the left side up, the stomach up, and here we see the breech presentation. The evaluation of the fetal heart in the 21-24 week screening uses 5 views proposed by Simcha Yagel. These are transverse views that begin at the level of the upper abdomen and end at the level of the upper mediastinum, and it starts with the abdominal situs, the 4-chamber view, the left ventricular outflow tract view, the right ventricular outflow tract view, the 3-vessel view, and the 3-vessel trachea view. We can see the abdominal situs, the 4-chamber view, the 5-chamber view, the aortic outflow, the right ventricular outflow tract, and the 3-vessel and trachea view. Let us begin with the first view, which is the abdominal situs, where we can see the fetus here in a cephalic presentation with the back on the left lateral side. The first view is the standard upper abdominal transverse section, where we will see the posterior aorta, and to the left, the anterior inferior vena cava, and to the right, the stomach on the left together with the spleen, and here the umbilical vein. Here, the fetus is in bridge position with its back on the left, the stomach is on the left, the aorta is posterior on the left, and the inferior vena cava is on the right and anterior. This view is very important because we may be dealing with an abnormal condition, such as, for example, complete situs inversus here, the mirror image arrangement. We may also be seeing this view as the first warning sign that we are facing an anomaly, a congenital heart defect, such as heterotaxy or isomerism syndromes. For example, here in right isomerism, we will see the aorta and the inferior vena cava aligned side by side. And in left isomerism, we will see the aorta with this vessel next to it, which would indicate interruption of the inferior vena cava and continuation as the azygos vein. So this view is very important because once we obtain it, we may suspect that we are facing an abnormal condition if there is a congenital heart defect and heterotaxy syndrome. Now, we are going to evaluate the 4-chamber view in general. We need to analyze that the heart is in levocardia. Its axis should be at about 45 degrees plus or minus 20 degrees, and it should be in a normal position. The heart occupies 1/3 of the thorax. 1/3 is occupied by the left lung, 1/3 by the heart, and 1/3 by the right lung. All 4 chambers must be present, and there must be no pericardial effusion. The atria and the ventricles must be analyzed. They should be a similar size. The left atrium is posterior and the right atrium is anterior. Regarding the AV valves, the differential insertion must be evaluated. The tricuspid valve is more apical than the mitral valve, and its septal leaflet inserts into the interventricular septum, and there must be good ventricular function. Cephalic presentation to the right, the differential VT insertion, the moderator band at the apex of the right ventricle, and a smooth left ventricle. Cephalic presentation to the right, differential insertion of the tricuspid valve, moderator band at the apex of the RV, and the LV with a smooth appearance. The flap of the foramen oval that goes from right to left, and it is always recommended not to forget the evaluation with grayscale imaging and with color Doppler of the pulmonary veins. In the apical 4-chamber view, this is the left and this is the right. The differential insertion of the tricuspid valve is more apical than the mitral valve. We see the trabeculated right ventricle, the moderator band, the smooth left ventricle, the atrioventricular valves open and move freely. The foramen oval flap goes right to left, and the pulmonary veins enter the left atrium. The heart must be analyzed in different positions. A lateral 4-chamber view, an intact interventricular septum, the cardiac crux, the foramen oval flap from right to left, the AV valves move freely, and here on grayscale, the entry of the inferior pulmonary veins into the left atrium. There is no pericardial effusion. A basal 4-chamber view, the cardiac crux, right chamber, left chamber, and assess that the ventricles are the same size. There should be no hypertrophy of their walls. The moderator band must be in the right ventricle at the apex of the right ventricle. The interventricular septum must be intact. The AV valves form the crux of the heart. We need to see the septum primum near the crux of the heart, and the valves open and move freely. Do not forget the differential insertion of the tricuspid valve, which is more apical than the mitral valve. So we also have to evaluate the heart rate and the rhythm. We have a normal heart rate that fluctuates between 120 and 160 beats per minute. In the second trimester, there may be transient bradycardias and tachycardias that are benign. However, when they are persistent, we are already dealing with a pathological arrhythmia. These arrhythmias, the most common, are supraventricular premature beats, which disappear toward the end of pregnancy or after childbirth and are benign. And the tachyarrhythmias are like flutter. For example, here we see atrial flutter, and here in M mode the sawtooth image, and also the bradyarrhythmias such as complete AV block, which can cause hemodynamic compromise in the fetus if it is not treated. The heart rate must be recorded simultaneously using M mode for the atria and ventricles, and it is necessary to assess that each ventricular contraction is preceded by an atrial contraction. If we perform the four-chamber view in the second trimester, we will only detect 30 to 40% of congenital heart disease. When we add the outflow tracts to the four-chamber view in the general population, the detection rate increases to about 60 to 70%. That is why it is very important to perform a complete cardiac screening so that no heart defect is missed. We are going to enter the outflow tract view. The great arteries have a similar diameter. They are the same diameter. Each artery emerges from its respective ventricle, the pulmonary artery from the right ventricle, and the aorta from the left ventricle. They cross at a 90-degree angle after their origin. Here we can see an X because there is a 90-degree crossing. The pulmonary artery is anterior and the aorta is posterior, so there is a 90-degree crossing there. We will start with the five-chamber view. The aortic outflow, we will see three vessels, and the last view at the level of the superior mediastinum, which would be the three-vessel trachea view. Technique: three ways to examine the outflow tracts. First, angle the transducer toward the head. This is the sweeping technique starting from the apical four-chamber view. We will go from the four-chamber view, angling toward the head, to the five-chamber view, the three-vessel view, and the three-vessel trachea view. We apply color Doppler, and both must be the same color from anterior to posterior. So this is the sweep technique when the heart is in an apical four-chamber view. By angling the transducer toward the cephalic pole, we move from four chambers to five chambers, to the three-vessel view, and to the three-vessel trachea view. This is the sweep technique. Starting from the four-chamber view, five-chamber view, three vessels, and three-vessel trachea view. The second is the rotation technique. When the heart is in a lateral four-chamber view, rotate and angle the transducer toward the right shoulder so that we will move through the four-chamber view, five-chamber view, three-vessel trachea view, and lastly, the other technique would be to move the transducer toward the fetal head, sliding the transducer toward the fetal head. These three techniques have the same objective: to evaluate the outflow tracts, the three-vessel view, and the three-vessel and trachea view. In the left ventricular outflow tract view, or five-chamber view, where the aorta emerges from the left ventricle, it should be assessed in grayscale that the semilunar valves disappear in systole and appear in diastole. So the aorta emerges from the left ventricle. There is continuity of the interventricular septum with the anterior wall of the aorta, and there is continuity of the posterior wall with the anterior leaflet of the mitral valve, mitro-aortic and septo-aortic continuity. It does not bifurcate immediately. It crosses the pulmonary artery at 90 degrees, and it has a size similar to that of the pulmonary artery. Here we see a five-chamber view. This is the left side, and this is the right side. We can clearly see that the aorta arises from the left ventricle with continuity with the interventricular septum and with mitral aortic continuity. Here we can see how the semilunar valve moves. It disappears during systole and appears during diastole. It is not echogenic, and it moves freely. Here we see a portion of the ascending aorta. When we apply color Doppler, we will see normal antegrade flow in the ascending aorta, and then we move to the right ventricular outflow tract view. It is necessary to confirm that the pulmonary artery arises from the right ventricle, from the anterior ventricle, which is similar in size to the aorta, that it crosses the aorta at a 90-degree angle, that the pulmonary valve also moves freely and is not thickened, that the artery bifurcates into its right branch and its left branch, and that it has normal pulmonary flow. In the three-vessel view, we see the pulmonary artery here continuing into the ductus arteriosus. The right ventricular outflow tract should always be evaluated from left to right, from anterior to posterior, and from largest diameter to smallest diameter. That is, the pulmonary artery has a larger diameter than the aorta, and the aorta has a larger diameter than the right superior vena cava. The right ventricular outflow tract, here we can see it in this static image. And here we see the pulmonary trunk, the semilunar valve that opens and closes, appearing and disappearing. Here we can see the branches of the pulmonary artery, the right branch, the left branch, the aorta, and the vena cava, always from left to right and from anterior to posterior. The three-vessel view was proposed by Yu and is used to evaluate the pulmonary artery, the ascending aorta, and the vena cava to assess their size and their relationships. Lastly, the three-vessel trachea view, which is the final view of the upper mediastinum proposed by Yagel, where we will assess the ductal arch, the transverse aortic arch, the vena cava, and the trachea. The trachea is located to the right of the ductal arch and the transverse aortic arch. As I mentioned, this view was proposed by Yagel in 2001 and describes the most cephalic portion of the transverse aortic arch and its relationship to the trachea. The ductal arch and the aortic arch are positioned to the left of the trachea, and they come together at the level of the descending aorta, forming a V, and there must always be antegrade flow when color Doppler is applied to both, and it must always be the same color. It is important to mention here that this reference to the ductus, which is shown here in the initial part of the pulmonary trunk, is misplaced. This is an error in the reference. We can say that the ductus is here at the convergence of the V. There is the ductus. That is the location, the ductus arteriosus. That is the normal location. From left to right, the three-vessel and trachea view shows the ductal arch, the aortic arch, the vena cava, and the trachea. The trachea is to the right of the transverse aortic arch and appears as a hyperechoic ring surrounded by an anechoic halo, which is fluid. When the fetus is in inspiration, then we see the ductal arch, the transverse arch, the vena cava, and the trachea. Therefore, the three-vessel trachea view will allow us to detect conotruncal heart defects and ductus-dependent heart defects, as well as a right aortic arch and a double aortic arch, which cause vascular rings. We have completed the cardiac screening by performing the 5 views proposed by Yagel. Here is a summary: the abdominal situs, the 4-chamber view, the 5-chamber view, the 3-vessel view, and the 3-vessel trachea view. It is important that when we perform the 21 to 24-week ultrasound, we must obtain these views as a mandatory part of the exam and document them both on the ultrasound machine and in the images that are provided to the patient. 4-chamber view, 5-chamber view, 3-vessel view, and 3-vessel trachea view. We must consistently store and save these images on the ultrasound machine and also back them up with the images that are provided to the patient. What factors influence the prenatal diagnosis? The main factor is experience, meaning having a lot of exposure to exams, many 21, 24-week screenings. There are also disadvantages that are circumstantial factors such as maternal obesity, transducer frequency, older or poor quality ultrasound machines with low frequency transducers, abdominal scars, amniotic fluid, oligohydramnios or polyhydramnios, which will be a disadvantage for performing the exam, and fetal position. But above all, the factor that will most influence the diagnosis of heart disease will be experience. How are we going to improve? With continuous training, the possibility of referring for a fetal echocardiogram when we suspect a heart condition, access to fetal heart specialists, and there must be feedback. Dr. Lindsay Allen, who is a pioneering world leader in fetal cardiology and well known to all of us for the books she has published, is very practical and says that the prenatal diagnosis of congenital heart disease depends on 2 points. First, the technical ability to obtain conventional intrathoracic cardiac images, which is achieved through understanding and practice of good views, proper acquisition of the views, the 5 views, that is one, and second, recognizing and accurately describing the difference between normal and abnormal. That is, she recommends that when we perform a 21-24 screening and suspect a congenital heart disease, we should refer the patient immediately with the diagnosis of a suspected heart defect, or when we do not confirm that the heart is healthy. If we suspect a heart defect, we should refer the patient to the specialist so that they can perform an echocardiogram and provide a specific diagnosis. In the Netherlands, a study was published that asked why heart defects are overlooked and what its objective was to identify the causes that lead to missing or losing suspicion of a congenital heart condition on the 21-24 week ultrasound. These authors found that the misdiagnosis was due nearly 50% of the time to poor image acquisition skills, that is, due to forgetfulness, omission, or simply because they did not know how to obtain Yagel's 5 views and therefore did not perform the screening correctly. The other 31% is because the defect is visible but not recognized. That is, they obtained good views, they obtained the 5 Yagel views, but they did not recognize the heart disease. And lastly, there is the 20% that is the inevitable loss. That is, these are heart diseases that are present but will become apparent practically in the third trimester or after birth, such as mild or moderate semilunar valve stenosis, pulmonary or aortic. Prenatal diagnosis of heart disease can indeed be improved, and these authors stated that it can be further enhanced by increasing the number of examinations performed by each sonographer per year. In other words, they recommend that the sonographer should be exposed to more than 250 cardiac screening exams annually. In addition to that, besides presenting screening exams, ongoing training, and quality control, that is, auditing. With this, an 80% diagnosis rate of heart disease can be achieved in the 21-24 screening. This will contribute to the prenatal diagnosis of heart disease. The use of color Doppler is not a requirement of the guideline, but it is highly recommended to perform it. Conventional color, Doppler, power Doppler, or high definition Doppler can be used, and here color Doppler will allow us to assess cardiac function. We will be able to see the patency of the atrioventricular valves. It will allow us to assess the filling of the cardiac chambers and the direction of flow in the great arteries, in the ductal arch, and in the aortic arch. Also in obese patients, color Doppler will allow us to further shorten the overall examination time to diagnose more subtle findings such as ventricular septal defects and also to evaluate the pulmonary venous drainage. We observe the entry of the inferior pulmonary veins into the left atrium with their normal morphology. This can be assessed in grayscale and with color Doppler. We are also going to assess the direction of the flows, antegrade flow. In this case, in the ascending aorta, we are going to see the filling of the chambers, the ascending aorta, and its antegrade flow in the 3-vessel trachea view, with the flow always the same color. And we are also going to look at the aortic arch and the ductal arch. Again, here we can use it. We can see how the chambers fill. We are going to look at the 3-vessel trachea view with color Doppler in grayscale, the ascending aorta. We apply color Doppler and we are going to assess that there is antegrade flow. There is no turbulence in the ascending aorta. Here in the 3-vessel trachea view, from left to right, we see the ductal arch and the aortic arch. And here I would like us to pause to look at the structure that arises here from the proximal part of the transverse aortic arch. The initial portion that would be the normal right subclavian artery that passes in front of the trachea. So we can also use the stick volume. Let us look here at how the chambers of the heart fill and how the crossing of the great arteries is seen, a 90-degree crossing. Let us look here at the heart, the aortic arch, the descending aorta. We can see the inferior vena cava reaching the right atrium. Here we see again the heart, the aortic arch, the inferior vena cava, the hepatic vein, and here we see the entry of the ductus venosus. Application of color Doppler. Color Doppler is also important for evaluating findings. By achieving proper settings, the sonographer can improve diagnostic capability by using color Doppler, power Doppler, and stick volume. And there are signs that most of us are familiar with. For example, the V sign, which is the three vessel and trachea view, where a V is seen at the convergence of the ductal arch, the transverse aortic arch, and the descending aorta. And here we have added some signs, such as the horseshoe sign, when there is a normal four-chamber view. That would be the septum, and this would be the foramen ovale. The horseshoe sign, the mountain sign, because it is the five-chamber view plus the transverse aortic arch, and the letter Y sign, which is also here, the trunk, the pulmonary artery and its branches, three vessels. Here we see the four-chamber view that resembles a horseshoe. Here we see the Y-shaped sign. When this sign disappears on one side or the other, it could raise suspicion of a ductus-dependent heart disease, either right or left-sided. We see the Y sign. Here we see the filling of the pulmonary trunk in the right branch and the left branch. Horseshoe sign again in a second trimester pregnancy, horseshoe sign in a first trimester pregnancy, and the five-chamber view, which is the ascending aorta emerging from the left ventricle, going toward the right shoulder, toward the transverse aortic arch, and is somewhat similar to a mountain. When this view shows the mountain sign because it has the shape of a mountain, and when this view changes, that is, it disappears and becomes an ascending aorta, or in this case, it would be a conotruncal heart disease, where the vessel that emerges from the left ventricle goes, it no longer makes the mountain sign. Instead, it goes downward and posteriorly, and therefore we would be looking at a sign that we have compared to a sea lion, as we can see here, indicating a conotruncal heart disease that would be a transposition of the great arteries. The outflow tract view will improve the detection of heart defects. As I mentioned, conotruncal heart diseases, a malaligned VSD, a truncus arteriosus, a transposition of the great arteries, tetralogy of Fallot, and double outlet right ventricle. If we do not perform a thorough, complete cardiac examination and evaluation, and we only rely on the four-chamber view alone, we are going to miss the majority of these conotruncal heart defects. What are the indications for echocardiography? Due to maternal indication risk, due to family risk, due to fetal risk, diabetes, epilepsy, obesity, lupus, high-risk aneuploidy screening without an invasive test, maternal heart disease due to family risk, a previous child with congenital heart disease, and a parent affected by congenital heart disease. And the indications for echocardiography due to fetal risk are when all aneuploidy markers are abnormal, the ductus venosus shows a reversed wave, increased nuchal translucency, suspicion of fetal congenital heart disease on the 21 to 24 screening ultrasound, extracardiac malformations, chromosomal abnormalities, fetal hydrops, torch, polyhydramnios associated with an incomplete cardiac evaluation, early intrauterine growth restriction, monochorionic twin pregnancy, fetal arrhythmias, and treatments in patients with anti-inflammatory medications such as NSAIDs, which may cause closure of the ductus arteriosus, especially when used beyond 30 weeks. The most effective indications for fetal echocardiography are up to 70% due to suspicion of a congenital heart defect on the 21 to 24 week screening ultrasound. In 25% to 40% of cases, it is due to detection of an abnormal aneuploidy marker on the first trimester screening, and the remaining indications are solely due to maternal-fetal causes, which account for only 10% of diagnoses. Regarding the views of the aortic arch and the ductal arch in the sagittal plane, they are not part of the guide, but it is good to remember that in the sagittal view, the aortic arch arises from the center of the heart, gives off its supra-aortic branches, forms the aortic arch, and then continues as the descending aorta. The diameter of the arch must be evaluated. Color Doppler should be used from the aortic valve to the descending aorta, always confirming its antegrade flow and quantifying its velocities. This is not part of Yagel's 5 views, and we are only evaluating it in order to improve our diagnostic capability. Here we see the aortic arch and the supra-aortic vessels. Here we see an anatomical specimen in which the ascending aorta, the brachiocephalic trunk, the left carotid, the left subclavian artery, and the descending aorta can be seen. We see the supra-aortic branches. This would be the left subclavian artery, the isthmus. And here is the opening of the ductus arteriosus. The isthmus is located between the left subclavian artery and the opening of the ductus arteriosus. We see here forward flow in the aortic arch, the ductal arch. The ductal arch is straight. It arises anteriorly and is straight like a golf club. Its velocities must also be quantified. The velocity of the ductus arteriosus does not exceed 150 centimeters per second at term, and as I said, it has the shape of a hockey stick or a golf club. Ductal arch with antegrade flow. It is straight, and the pulmonary valve, the ductal arch, the ductus arteriosus, and the descending aorta are visible. Pulmonary artery ductal arch, ductus arteriosus, descending aorta, systemic venous drainage, the seagull sign, the inferior and superior vena cavae draining into the right atrium when the fetus is in an anterior back position, when the fetus is in a posterior back position, systemic venous drainage. And lastly, when we suspect a heart condition, we request a fetal echocardiogram. The echocardiogram is an evaluation of the heart to assess cardiac function, structure, and heart rhythm. M mode is used, as well as pulse Doppler. Velocities must be evaluated along with color Doppler. Here we are evaluating the ductus arteriosus. Here we are evaluating the aortic isthmus. Here we are evaluating aortic velocity. Here we are calculating the myocardial performance index, where we will see the aortic isthmus in the 3-vessel trachea view and the isthmus in the sagittal view. We will assess cardiac function with M mode, the left ventricular shortening fraction, which is normally greater than 28%. We will assess the PR interval. Here we can see it better. The mechanical PR interval, which is normally up to 140 milliseconds, and it is the time from when atrial contraction begins to when ventricular contraction begins. And when the PR interval is greater than 150 milliseconds, we will refer to first-degree block. The myocardial performance index, or modified TEI, is the result of adding the isovolumetric contraction time plus the isovolumetric relaxation time divided by the ejection time, and the normal value for this is up to 0.45. In conclusion, we can say that congenital heart diseases are the most common malformations and the least diagnosed, and 90% of congenital heart diseases occur in patients who have no risk factors. Therefore, it is necessary to perform cardiac screening for all patients. Cardiac screening should always be performed for all patients at every stage of pregnancy, not only at the 21-24 week ultrasound. Fetal cardiac screening becomes an integral part of the 21-24 week anatomical ultrasound. It must be performed, and every sonographer, every obstetrician gynecologist who performs ultrasounds, every ultrasound physician or perinatologist who performs a 21-24 week ultrasound must obtain the 5 Yagel views, must always do so, and cannot perform an anatomical ultrasound if they are not qualified to obtain the 5 Yagel views. You cannot do it. You should not perform a procedure, a 21-24 screening, if you do not know, and if you do not know how to obtain Yagel's 5 views. A high index of suspicion is required for the diagnosis of severe heart diseases. A serious heart condition should be suspected, and the patient should be referred so that a fetal echocardiogram can be performed by the perinatologist or the pediatric cardiologist. And what we always have to observe and document in our examinations. Here again, what I mentioned, the 5 views proposed by Yagel, the abdominal view, the 4-chamber view, the 5-chamber view, the 3-vessel view, and the 3-vessel trachea view must always be included in our 21-24 week ultrasound. Are you performing an optimal examination of the heart during the 2nd trimester ultrasound? If everyone who is here right now is performing the 5 views proposed by Yagel, is complying, is documenting it, is giving the patient the report with the images of the 5 views, you are contributing to the diagnosis of congenital heart disease and improving these children's survival and quality of life. Thank you very much. For those who would like to make an inquiry, ask a question, or share a concern, I am leaving my email address here. Thank you very much for your attention.